Welcome to this explainer, where we're going to completely break down the foundational, ethical, and systemic frameworks that power modern professional nursing. We are diving deep into Chapter 1 of the Fundamentals of Nursing today, pulling back the curtain on everything from the historical evolution of the practice all the way to the critical, absolutely crucial importance of clinical documentation.
So let's just jump right in and challenge some old preconceptions. Ask yourself what really goes into the rigorous, behind the scenes world of the modern nurse. Because let me tell you, it is so much more than just the vintage cap, clean scrubs, and following doctor's orders. We're talking about a high stakes, technologically advanced environment that requires incredibly complex decision making every single day.
To make this massive topic digestible for us, we're going to hit 5 core pillars today: foundations of nursing practice, nursing ethics and law, healthcare delivery systems, cultural competence in care, and finally, clinical documentation.
Let's start right at the beginning with our first pillar, foundations of nursing practice, looking at its evolution, theory, and advanced roles. The dynamic evolution of nursing is honestly astounding when you lay it all out. We start way back in the 1850s with Florence Nightingale's lamp, which really set the initial stage for foundational care and hygiene. Fast forward 100 years to the 1950s, and we see Virginia Henderson defining her 14 basic needs theoretical framework. By the 1970s, Jean Watson introduces her theory of caring, heavily emphasizing that crucial human connection between a nurse and their patient. And now, look at the 2020s. We've transitioned to modern telehealth tablets, digital interfaces, and incredibly advanced practice roles. The transformation is literally night and day. And speaking of those modern roles, let's instantly bust a major historical myth right here. That old idea that nurses simply exist to follow orders? Yeah, entirely outdated. The fact is, today's nurses are highly autonomous clinical decision makers. This is especially true when we look at advanced practice roles that are actively shaping modern healthcare. People like certified registered nurse anesthetists, nurse practitioners, clinical nurse specialists, and nurse educators. They are driving the clinical narrative, not just reacting to it.
So, you might be wondering, how do these professionals process all that complex information to make autonomous decisions? Well, they use established frameworks like Maslow's hierarchy of needs. Imagine this as a pyramid. Nurses logically prioritize patient care layer by layer, building from the ground up. They have to address the most urgent, foundational physiological needs, like, airway and breathing first, before they can ever move up the pyramid to address higher level psychosocial and emotional support. Okay, moving on to our second pillar, nursing ethics and law. These are the strict rules that govern practice. Listen, every single clinical choice is a high-wire balancing act. Nurses are constantly weighing 2 core ethical principles. On one side, you've got the ethical drive of beneficence, which essentially means actively taking steps to help others and acting in the patient's best interest. But on the other side is the strict mandate of non-maleficence, which is the foundational, non-negotiable commitment to do no harm. Balancing those two, it's a constant, everyday challenge. To ensure safety during that balancing act, every single state maps out its own Nurse Practice Act. And let's be clear, this isn't a mere suggestion. It serves as the ultimate legal boundary. It strictly outlines a nurse's authorized scope of practice in that specific jurisdiction, dictating exactly what they are legally permitted to do, and, just as importantly, what they are not.
Now, there is a critical distinction in tort law that you are going to hear all the time: negligence versus malpractice. Negligence is a general misstep, a failure to take proper care that honestly anyone could make. But malpractice, that is a whole different ballgame. That is a direct failure by a licensed professional to meet established standards of care, which results in actual harm to the patient. So how on earth do nurses navigate this legal obstacle course without crashing? They protect their patients and themselves by strictly adhering to legal shields. They follow those established standards of care and lock down patient privacy with strict HIPAA compliance for all digital medical files. They meticulously run through informed consent checklists prior to any surgical prep to make absolutely sure the patient is fully aware of what's happening. And they expertly manage complex ethical dilemmas, constantly weighing a patient's autonomy to make their own choices against paternalism, where a provider might be tempted to override those choices for the patient's quote-unquote own good. This brings us to a major reality check on liability. It is a very dangerous myth to assume institutional immunity. The idea that the hospital is just going to cover you for everything. The hard fact is that nurses carry significant personal liability.
They can absolutely be sued as individuals, and they are held personally accountable to those strict standards of care we just went over.
All right, let's zoom out a bit for our third pillar, healthcare delivery systems, navigating the macro environment.
Healthcare delivery is structured in escalating tiers, essentially building up in complexity. It starts right at the foundation with primary care, which you'll find in local clinics and is heavily focused on preventative health and wellness. Then it steps up to secondary care for more specialized clinical interventions and standard hospitalizations. Finally, it reaches tertiary care, involving those massive, technologically advanced hospital complexes designed specifically for highly complex intensive care needs.
Now, when we look at how we actually fund these massive, complex systems, it generally comes down to two primary eligibility wallets. First, we have Medicare. That's an age-based federal entitlement program primarily supporting adults 65 and older. Then we have Medicaid, which is a joint state and federal needs-based assistance program specifically designed to support low-income individuals and families. Inside these large systems, highly functioning care totally relies on a collaborative, interprofessional team. Picture physical therapists, occupational therapists, pharmacists, and MDs all orbiting the patient. Our clinical pearl for keeping this orbit stable is the SBR communication acronym: Situation, Background, Assessment, and Recommendation. SBR acts as a vital communication bridge, allowing nurses to seamlessly and clearly transfer critical information to other providers without missing a single beat.
Furthermore, systemic quality is never left to chance. It's driven by the robust QSEN structure, quality and safety education for nurses. It demands seamless continuity of care, closely tracking a patient from admission, right through discharge planning, and into home health. And pay close attention to this last point: real-time HCHPS scoreboards. These patient satisfaction surveys directly tie hospital reimbursement to the patient's experience. So yeah, in modern healthcare, the quality of care and patient satisfaction literally dictate the financial health of the hospital.
Let's move on to our fourth pillar, cultural competence in care. This is all about truly connecting with the patient.
There is a massive misunderstanding in healthcare regarding cultural competence. The myth is that it's just about memorizing a checklist of symbols or dietary facts. But the reality? It is an ongoing, lifelong practice. It requires deep cultural humility and constant skill building to truly understand and respect the beautifully diverse backgrounds of the patients you're treating.
True patient-centered care radiates from specific, intentional actions. It means utilizing frameworks like the Campina-Bocote model to actively desire and seek out cultural encounters. It requires active listening and intentionally wiping away the foggy lens of implicit bias that can obscure our view of the actual person in front of us. It means deploying tools like certified medical interpreter tablets to safely break language barriers, rather than just relying on their family members in the room. And crucially, it involves addressing the social determinants of health. Because let's be real, you simply cannot drive clinical recovery if a patient lacks secure housing or reliable access to food. Our big clinical pearl in this section is the teach-back method. This is a vital communication loop. Instead of a nurse just asking, "Hey, do you understand?" they actually ask the patient to repeat the care instructions back to them in their own words. This strategy is a total game changer. It completely eliminates guesswork and ensures the patient truly grasps their care plan before they ever walk out the facility doors. Finally, we've reached our fifth and final pillar, clinical documentation and the electronic health record, protecting the medical record. Nurses feed an incredible amount of data into a centralized patient cloud every single shift. They use different architectural blueprints for this medical record, such as narrative formatting, focus charting, or structured SOAP styles. But no matter the style, they are always guided by the FACO acronym. Every entry must be factual, accurate, complete, current, and organized. And it must be done in real time. Charting at the very end of a long, exhausting shift is a total myth of efficiency. Real-time documentation is what actively prevents critical, life-threatening errors from happening on the floor. To wrap up this explainer, I really want to leave you with a heavy legal truth that defines the whole profession. If it wasn't documented, it wasn't done. It's the ultimate reality check for modern nursing practice. Think about it. If you don't chart your actions factually and in real time to protect your patient and yourself, how could you ever prove it actually happened in a court of law? Something to think about. Thanks for joining me for this one, and I'll see you in the next explainer.